Hi, my name is David Montgomery, and today we're going to be doing an examination of the hip and the groin. Thank you very much, Joe, for agreeing to be the patient. So before any hip examination, it's important to start with the back. So if you turn around for me, Joe, this is because back pathology such as disc disease, degeneration, or SI joint pathology can cause particular pain right into the groin, which can confuse the diagnosis. So we're going to start by looking at the alignment. So he has a good straight spine. There's no evidence of scoliosis. We're going to look as well either side to look for any hypertrophy or atrophy of the muscles, but there's good muscle bump there. Now if you can turn to the side for me, Joe. Lovely. So now we want to look at the curvature of the spine. So we can see from the side that there's good lumbar lordosis going into thoracic kyphosis and cervical lordosis, which is normal. Lovely. From this position, we can then do a special test called the Stork test. Joe, if you can just stand on your right leg, keeping it straight for me, and then lean back. Good. And back up. If that causes pain in the back around the SI joint, that can be suggestive of spondylolisthesis or SI joint pathology. So have a seat for me, please, Joe. Now this is stabilizing the pelvis for a better examination. We can now palpate the spine all the way down, looking for any signs of tenderness, but also looking again for scoliosis. We then want to palpate the medial and lateral muscle bulks, looking again for any tenderness. Palpate over the SI joint, again for tenderness. Lovely. Now if you can flex forward for me, please, Joe. So this gives us a better, gives us an idea of how far you can flex, but also will exacerbate any evidence of scoliosis. While I stabilize the pelvis, can you lean back for me, Joe, into extension, seeing the extent of lumbar lordosis and up, good, which is good. Now flex to the side for me, and to the other side. So this is assessing the flexibility of both sides, which is symmetrical. Lovely. And then if you rotate over your right shoulder and over your left shoulder. Good. Lovely. Right. So it's good flexibility, range of movement, and it's all symmetrical throughout. And if you can lie up in the bed for me, so we're going to move over this side of the camera. So to complete the test, we're going to do a quick neurovascular examination. Throughout all of the examination, we're only looking at one side. Ideally, of course, in the real world, we'll be doing both sides for comparison, but for time reasons, we do this. So we want to do a neurovascular examination quickly, checking the pulse in the posterior tibialis, and then dorsalis pedis. Pulse to the present, good. Wiggle the toes for me. Lift the toe up against me, good. And the ankle up. Don't let me push it down. Push down as if on an accelerator. That's good. Can you feel me touching there?
Yep.
And there?
Yep.
Here?
Yep.
Here?
Yep.
Here? Good. So there's good sensation neurovascular intact throughout. Now we want to move on to the provocation test. So if you can keep your legs straight and lift up. Good. And down. So if that caused pain that shot past the knee towards the foot, that's suggestive of a sciatic nerve impingement or disc disease. We can, in that position as well, we can go up to the first point where he feels pain, then we can dorsiflex the ankle. If that exacerbates the pain, that's a positive tension test. Similarly, if we plantarflex or bend at the knee, and that eases the symptoms, that again is positive for nerve impingement, and that suggests the pain is coming from the back. Now we're going to move up to the hip and the groin. It's important in these cases to get a very good history about where the worst pain is. If it's in the anterior groin, it's likely an acetabular problem, either a labral tear, avascular necrosis, or degeneration. If it's over the greater trochanter, then it's likely to be trochanteric bursitis or greater trochanteric snapping hip. If it's more posteriorly in the buttock, it might be hamstring insertional tendinopathy or sciatic nerve impingement. So then we want to move on to palpation. So we want to feel for the anterior superior iliac spine, which is the insertion of sartorius. Then we want to feel for inferior superior iliac spine, insertion of rectus. Moving over to the pubic rami, which can be tender in a stress fracture, and to the symphysis pubis, which again can be tender in otitis pubis. So then moving over to the lateral aspect, feeling for the superior iliac crest, which can be tender in iliac crest epiphysitis, or if there's been iliac crest avulsion from the lumbrical muscles. Then palpating over the greater trochanter can be tender in trochanteric bursitis or greater trochanter snapping hip. Then you can roll onto your side for me, Joe. If you roll this way, we'll come around just for the camera. So obviously it's a changing leg, but for the purpose of being able to see. So then you want to feel over the ischial tuberosity, which is the insertion of the hamstrings tendon. And if that's tendon, maybe it's just a hamstrings tendinopathy. A bit more proximal is where the sciatic nerve comes out, and if that causes numbness or tingling down the back of the eye, suggests a sciatic nerve impingement. Relax back from the So now we want to assess flexion. So if you can lift your leg to your chest for me. Good, so he's about 120 degrees flexion and down. And then we're going to move the leg out. So he's good abduction. We're going to cross it over into adduction. And again, of course, we'll be comparing both sides. Now bend up, and we're going into internal rotation of the hip and external rotation of the hip. Good, level both sides, lovely, and relax. Now if you can roll over onto your front for me. We again look at internal, external rotation, but it's better in this position. So hips at 90 degrees, so external rotation and internal rotation. So that's good when equal both sides. We'll actually roll back for me. Now I want to assess flexion contractures. We can do this first by bending the hip to 90 degrees. Check the hamstring, nice and relaxed for me, Joe. And bring up to there where there's a rigid endpoint, relax. So it goes to about here, which is again only about 120 degrees. So there's some element of a hamstring contracture. Then if you're going to do a modified a Thomas test, so bend both hips up and tuck them up onto your chest with your arms. So cross your arms over, nice and tucked. So that stabilizes the lumbar spine and the pelvis. Now let go of this one, hold on to the left, and relax it all the way down. So as it's able to touch the bed, there's no evidence of a hip contracture, and you can relax this one down. If it was raised up, then it'd be suggestive of contracture. So now we're going to move on and assess motor function and strength. If you can keep this leg straight and lift it off the bed for me, Joe, the right leg, push against me. That's assessing quadriceps, which is good. Relax the knee, pull your knee to your head against my hand. That's against iliopsoas, which is good. Now squeeze your legs in nice and tight. That's lovely. That tests gracilis, adductor magnus, and adductor longus. Excellent. And now out against me. This tests IT band and gluteus, which is strong. Good. Now I want to assess for the strength of sartorius and pathology sartorius, which flexes and rotates the leg and crosses two joints. So we want to bend the knee, cross over the leg, and then pull up as if along your shin, Joe. Pull up against me. If that causes pain, it suggests that the pain is coming from the sartorius. Lovely. Then we also want to do it into internal and external rotation. So push out against me. Push out against me. Lovely. Pull in towards. So that was internal, and this is external rotation. Pulling in. Lovely. And if external rotation is tender, it may suggest a piriformis syndrome. So having done those movements, we now want to move on to special tests. So the first test we're going to use or assess for SI joint pathology. We've already done the Stork test, which was negative. So the next test that we're going to do is Faber's, or flexion, abduction, and external rotation. So we put the leg flexed up, externally rotated, and abduct the leg. And with the same time, we want to stabilize the pelvis and push out against. And in that position, if that causes pain, there's a positive Patrick's test or a positive Faber test, and is suggestive of SI pathology. Now, if you can roll onto your side for me, Joe. Okay, I'm just going to move around from the camera. So similarly, we can do the compression test, where we just push down on the pelvis as the SI joint is a stabilizer. If that causes pain, it's suggested in the posterior region, suggested SI joint pathology. From this position, we go into the special test looking for piriformis syndrome. We can feel deep into the gluteal muscle, feeling in there. If that causes pain or tenderness, again, can be suggestive of piriformis syndrome. Roll back on your back of me. Now we've already tested resisted external rotation, which again is for piriformis syndrome. And the last test that we can do is flexed adducted. So we bring the leg over, forced into adduction, and looking for any sign of pain. And if that causes pain again in the back, that suggests positive for piriformis syndrome. So from that position, then we want to look for any signs of stress fracture. So to do that, we want to do a percussion test. We lift the leg up and we hit against the heel, causing vibration. We bend at the knee, and again hit down at the top of the femur, and then straighten the leg and hit against the greater trochanter. If those vibrations cause pain, it can be suggested that there's a stress fracture. More commonly, however, you elicit a stress fracture through extreme ranges of movement, so you'll bring it up into flexion. Internally rotate, externally rotate, bring it out, and into extremes. So that causes pain, and extremes can be suggestive of stress fracture. And of course, if clinically suspicious, you should organise follow-up imaging to rule that out. From that point on, then the next special tests we want to do are looking at evidence of snapping hip. There's three types of snapping hip: the iliopsoas, greater trochanter snapping hip, and labral tear and loose body. So iliopsoas and labral tear are likely to present snapping hip within the anterior groin, whereas greater trochanter snapping hip will be on the over the greater trochanter. From that point of view, Joe, if you can roll onto your side again for me. So to do that, we feel over the greater trochanter, bring the leg into extension, and we want to move it around in full range of movement into extension, trying to feel for that snapping hip. You feel clunking or snapping, that's suggestive. Similarly, we can pull the leg into extension and try and lower it down. Ober's test, if the knee is not able to get past the level of the other knee, suggests a tight IT band, and that can be suggestive of snapping hip. Going back on the side then, we want to test for iliopsoas snapping hip. What we do is flex the leg, put it into external rotation, feel in the groin, and ask Joe now straighten the leg, so as it internally rotates and extends and brings it back and repeats, we try and feel again for that clunking or snapping within the hip. You can relax down, lovely. And so finally then we want to assess for the labral tear. So in order to do that, we want to catch the labral tear throughout our range of movement. So we're going to do deep range of movement. We want to feel with one hand, link the leg in your arm, put it into flexion, internal and external rotation. You're really trying to catch that labral tear as you bring the hip around. You can't feel the anterior going to the posterior, again moving it around, trying to catch that. Don't relax down. Then you can roll over and the other side, again just from the camera, this way. You can feel in the posterior aspect, and again you just want to bring it into the range of movement as you try and catch that labral tear against your hands. And you can roll back around to me. And if you're concerned, if it's possible if a labral tear, you should organise an MR arthrogram. Okay, so that completes my examination of the hip.